Okay, so we're here for another podcast. I'm with Mr. Martin Klinker, who I've worked with for a very long period of time. We're going to talk about bunions, Martin's favourite topic. So Martin, do you want to just give yourself an introduction?
Yeah, thank you, Chris. Martin Klinker, my name, a foot and ankle surgeon, so orthopedic specialist, but also trained in sports medicine. Covering the whole spectrum below the knee, so Achilles tendon problems, ankle, forefoot, bunion, plantar fasciitis, the whole spectrum. But I see a lot of, especially women with bunions, and there's
So
lots
let's
to
kick
talk
it off.
about.
What is a bunion, Martin?
So what is a bunion? Well, it's not something that has grown. So often people think, oh, there's bone growing. It might become more prominent. There might be some soft tissue swelling. So I recently had a referral. It's a soft tissue bunion. Yes, the patient had a bit of an inflammation of the soft tissue. Can even develop into a bursa because of the footwear
So you see
pressing.
that bump on the
You see that
outside.
there might be some redness. You can push on it. It's not firm. It's not a bone.
Yeah.
So it's normally an increased angulation between the second metatarsal and the first metatarsal. So normally it's 9 degrees between the two on a weight-bearing X-ray. But if it's bigger, that means one bone is going more out. And because that goes more out, the other one goes more in. So the toe goes more in, but the metatarsal bone goes more out. And that makes
So
it look
basically
like
you've
it's
got the
prominent.
bone going one way and the toe going the other.
Exactly.
Hence you've got that.
Yeah, but it's
Bump.
not that bone has grown.
No.
It's just the alignment of the first metatarsal in relation to the second metatarsal, and then the toe sitting on the first metatarsal is going the wrong way.
So that's probably a key thing straight away there, isn't it? Because if you look down at someone's foot or somebody has a bunion and they look down, they probably think they're getting more bone on the inside. But actually, it's related to the angulation of the toe.
There is not more bone here. It looks prominent. I get my finger straight. There is not more bone. It's just the angulation between the two bones. So at the end, sometimes we see a bit of the metatarsal head being a bit more prominent. Even the bone probably grows. But we sometimes see that, but that's not the bunion. That's just a bit of bone there. But the bunion is the malalignment between the first and the second metatarsal, and then certainly between the metatarsal and the big toe.
Okay, so I've got lots of questions actually. I didn't think I'd have so many about bunions. But so who gets it? Is it genetic? You know, there's that whole thing, oh, you should see my mum's toes, they're awful, so I know I'm going to get it.
Yeah.
Is that true?
There is truth behind that. It doesn't mean that your mum had it, you have to have it, and vice versa. But it's not, we can't often link it to footwear. So my mum had a horrible bunion, second, third toes like this. She never wore high heels. Yeah. She always wore good shoes. Yes, high heels, narrow toe box, all that can make it worse.
So wearing shoes like
too
high
tight.
heels, tight shoes.
But it doesn't mean that if you wear high heels all your life, you will get a bunion.
No.
It might make it more painful, more symptomatic. It's not good to do that.
No, sure.
You can sometimes wear a high heel when you are somewhere. You shouldn't walk too much around in high heels. But yes, you can get it. It's often genetics, but it's a lot more often women. Yeah. Women get it a lot more often. I always say Achilles tendon rupture, 9 out of 10 men, and bunion, 9 out of 10 women.
Yeah.
But you see men as well. When the men come with a bunion, they have a bad bunion. Right. It's really a proper painful bunion.
Yeah.
And I'm always surprised to see how long they waited. Women come often, and that's not because they can't cope with the discomfort. No. They might have other issues with it. And I just operated 2 days ago again on a young lady. I thought, should we operate? It's not very pronounced, but she said, it hurts. Yeah. It hurts. And I tested it, easily flexible. It's good. It's a good bunion. Yeah. As soon as you
What's
operate,
a good bunion?
A good bunion, not badly deformed, not massive soft tissue swelling around it.
Yeah.
Nothing affecting the second or third toe.
Right.
And the toe, and that's very important, I'm going to talk about it again, not being too much rotated, not much too.
So if you look down at your foot and you see that the nail is rotated, that's not a good sign.
That's not a good sign.
Right.
If it's still more or less parallel to the floor, that's a good sign. So she had a good bunion from that point, and not very deformed, and not excessively painful. And the second, third toe is absolutely fine. No overload of the second, third MTP joint. But as soon as you operate on the young women with a mild to moderate bunion, you often see a bit of excessive synovial fluid coming out of the joint.
So you, as in after the operation?
When you operate, you go in there, you look at the joint, and there's often like a meniscoid band.
So meniscoid being a bit of cartilage?
No, it's a bit like a thickened, like a ligament structure,
Right.
rubbing on the cartilage.
Like a capsule, I suppose.
It's a thickening of that,
Yeah.
more or less. And it rubs on the cartilage. And sometimes we see exactly in that position a bit of loss of cartilage.
Right.
And that irritation or that band that rubs across the joint is often the source of pain.
Fine.
And it's not
Did
the
you know that
severity.
before you went in?
Well, when
You suspected it.
you can't see that very well on imaging.
No.
But nowadays, whereas 20 years ago,
Yeah.
she complains she just wants to have a nice straight toe. But then I saw so many young women with exactly the same finding, and they're all doing good.
Yeah, that's
So it's
really
not that they
interesting.
have a severe bunion.
Yeah.
And I've seen ladies, I remember one lady in particular, mid-60s, horrible bunion. Does it hurt? No.
No.
Can you walk as much as you want to? Yeah. Do you still find shoes? Not that many, but I'm okay. Thank you.
Leave it. Yeah.
I can't
So-
get you better.
so
but
I
that
think-
lady
yeah.
didn't look bad,
Yeah.
but she had some symptoms. And
Yeah.
I'm sure, like all the other ones, they will get better because she had that pain because of the joint being
Yeah,
irritated.
yeah. That's interesting. That's that younger group.
Yeah, yeah.
So, a couple of things. I think it's obviously if somebody's, particularly women, are watching this and they look at their mum's feet and they go, "Oh gosh, I'm going to get bunions." I think the first thing to say is just because you've got a bunion or you're going to get a bunion
Yeah.
doesn't mean you're going to get pain
Exactly.
and in any way be limited in your life.
Yeah.
So actually, if we think about it, there's more people out there with bunions with no pain
Yeah.
than there is pain. So
Exactly.
what is it, and I genuinely don't know the answer to this, what is it about a painful bunion, and you've given one example, compared to a non-painful bunion? Is it the rotation, or is it as a result of the angulation they're starting to develop either arthritis in that toe or a toe next door?
The rotation is very important because if the toe is rotated, it doesn't take the weight anymore. So you've got a functional amputation more or less of the toe. It doesn't do a lot. If it's really
You might as well not have it.
Exactly.
Yeah, yeah.
Of course, we keep the toe.
Yeah, of course.
But it doesn't do a lot. So the pain can be linked to footwear because if it really sticks out, you can't wear shoes
So
properly.
it's just literally a rubbing of
It can
the
be rubbing.
shoe. Right, yeah.
And because you don't push off through the toe, you take more pain, more pressure, and therefore have more pain in the joint. But of course, the joint can suffer because you don't have a proper biomechanical mechanism of your gait pattern. But it's difficult to know why some do get some pain
Yeah.
and some don't. Yes, there might, with age, be some wear and tear in the joint as well. So, and that leads us, why should we do something about it as well?
So when do you operate?
Yeah.
Is it the pain? Is it the angulation combination?
Yeah, it's the patient description of symptoms. So pain is really the main reason. If the patient says, I just wanted to know, do I have to have surgery? I can cope with pain, don't have anything done. If they can't get into shoes anymore, not common, but if it's really bad bunion and you can't get into shoes
Just because
it
of
just rubs,
sheer
it
thickness of the foot.
absolutely,
Yeah, yeah.
that hurts. You can do the surgery. If the deformity is getting worse, you know, I can see it's getting more and more over the last weeks, last month. It's got worse. If it's more of a pronation, that rotation of the big toe,
Rotation, yeah.
you can do surgery. The only time when I tell the patient you must have surgery
Right.
is when the patient starts to complain of pain in the second toe joint.
As well as the first.
That's
Not
the most difficult one.
Yeah, yeah.
When they don't have any pain in the big toe, I had a bunion for 20 years, never hurt, doesn't hurt now, but they get pain in the second MTP joint.
Yeah.
You would normally do something about the big toe because it's responsible for the overload of the second toe. But normally, in the vast majority, patients then have pain in the big toe. It got a bit worse, but now I realize the second toe is starting to hurt. It might splay a little bit.
Right.
It might come up a little bit. And ideally, you don't want to get to that point. You want to hear the patient, I felt like there was something in my shoe.
Yeah, yeah.
So pain is getting worse in the big toe, but I feel something is happening with the big toe. That's when I tell the patient, you must have surgery to the big toe. Because if we have to then operate on the second or even the next
right,
toe
yeah.
area,
Before it gets
recovery and all that is a lot more tricky for you. Surgery is longer, but recovery is longer, and the outcome isn't as good.
Yeah.
So yes, there are various reasons. Pain symptoms from the patient in the big toe joint is a good reason,
Yeah.
But the only reason why we say you must really have surgery is when the second toe starts to hurt.
Right, that's interesting. So basically the big toe no longer, because obviously when we're walking, the big toe is such a powerful and
Absolutely.
big part of what walking and running is all about, that you can't put it through the first. So basically you go to the next toe.
And that's why they get...
That's when you get damage in the second.
Exactly.
So yeah, that's interesting, because if you leave it too long, then you've got a first and a second problem.
Yeah,
So
and
you're
often
trying to
the
prevent
third
that.
even.
Yeah,
Yeah.
absolutely. And what about footwear? So is it to do the width of the shoe? What do you find that generally you would advise for these
comfortable
patients?
shoes. It's not always easy. Someone who has a narrow heel to find a shoe that is wide enough.
Yeah.
The pressure from the footwear. Orthotics, they can't do too much.
No.
They certainly can't straighten the big toe. The only way to get a permanent straightening of the big toe is surgery.
Yeah.
What you can do, put a little bit of a little toe spacer at the smallest one you can get, because, as I said, there's a prominence. If you get it straight, there isn't that prominence. So it reduces a bit the pressure.
So sorry, that's a toe spacer.
Yeah,
so that's
between the
those
big toe and the
silicone.
second. So that's silicone. It doesn't straighten the toe, but
No.
it might reduce that prominence. In
Right.
addition, you can put some felt padding around the prominence, so there is no pressure from the footwear against that prominent bit, but more around the other bit.
Yeah.
Just to reduce your symptoms.
So that's two good tips there. Is maybe a little bit of felt,
Yeah,
but
around.
also the silicone that you put, basically the toe spacers.
Exactly. The
between
smallest
the
one, not
first-
a big one.
Not a big one,
No.
because that will overang you. It'll be
Yeah,
uncomfortable.
It's uncomfortable. And some patients hate it, but some say, yeah, it works.
Yeah,
for
I
me.
found that.
Yeah.
Again, it's some people get on with it, but also that will essentially, when it's in, straighten it. And there is a bit of a myth, isn't it, that if you wear that enough, it will end up straightening the toe, but that's just not going to happen.
No, but
I've had patients that go to bed with like 7 different silicone things in their toes, and it's just not going to make any difference, is it?
Especially at night, you don't need it.
Yeah,
I
exactly.
mean, there's that plastic thing that pulls it over and all that, and it's going to be...
So
Not
what's the
pleasant at night.
relationship? Because we've shared lots of patients where they don't necessarily have a bunion, but they do have arthritis in the toe, or that sort of an osteophyte at the top, that dorsal impingement. Are those totally different things, or are they normally part of the same spectrum?
No,
or?
they normally are separate.
Yeah.
You get, yes, the bunion in the elderly patient might have some wear and tear, and yes, they take a bit longer to recover because the joint got used to that for a long time, and the joint isn't happy straight away. But it's not common to see severe arthritic changes in a bunion. It can happen, but it's not common. The arthritis, the hallux rigidus or hallux limitus, is normally a different issue, with normally initially the top bony spur that hurts, especially towards the second toe.
Yeah.
They might have less flexibility, limitus rigidus, but the pain is more when you bend down the toe because the tendon and the soft tissue structures, they stretch over that.
Yeah.
So they
So a
have less,
bunion would normally be...
they still have a decent range of movement.
Yeah.
They might only have a good range of movement in the bunion position, so in the wrong position. You try to straighten it,
and they're stuck.
and there's less movement.
Right,
Yes.
interesting.
But they normally don't have that bony spur on top.
Yeah.
That's a different entity.
One of my clinics is in Chelsea. I definitely have a clientele that are quite concerned about how the bunion looks. So when they go on holiday, they think it looks ugly, basically. So they're not in much pain, but they're quite keen to, I suppose, have a cosmetic operation done. What's your opinion on that? Because I'm sure there's people out there doing it. What's your opinion on that?
They shouldn't do it.
Yeah.
I know that in New York, there are some women who have their little toe amputated, so they fit into the narrow toe
really?
box. Yes, that has been confirmed by quite a few. Yeah, we know that happens. I think in London it doesn't happen that patients have their toes amputated, but they can have potentially, they can find someone who would do surgery for the bunion for cosmetic reasons.
Yeah.
Cosmetic surgery should be done by a cosmetic surgeon, but a cosmetic surgeon wouldn't know how to operate
Yeah.
on a bunion.
Yeah.
So no, you should not have surgery purely for cosmetic reasons.
No, sure.
There needs to be a clinical reason for that. in
Which
the
would
sense of-
generally be pain somewhere on the
Yes.
foot. Yeah. So just playing devil's advocate on that, what if because you talked about damaging the second toe, and maybe, obviously, if you're in pain, you might do that bunion operation to prevent any further issues. Would that not, if you did do the bunion surgery, would that not maybe reduce the chances of getting that?
Well, you can do that if they start to have some symptoms in the second toe. But I wouldn't do surgery if they don't have any symptoms.
No.
You can do certain exercise, you can do other things
Yeah.
to prevent that overload, calf stretching, blah, blah, blah.
Because there's no guarantee it's going to cause pain, is there?
No.
So
a
there's no
bunion
point living
doesn't
in
have
fear,
to
is
hurt.
there?
As we said,
Yeah.
there are a lot of people with a bunion, they don't have any symptoms. There are people who have a mild bunion. They have a lot of discomfort for other reasons. The male often have a big pronation of the big toe. They often have a proper bunion, and that hurts. But no, you should not have surgery purely for cosmetic reason. There needs to be a reason to do surgery from a medical side, symptoms.
Because, and the reason being, as you said in an earlier podcast, is there is always that small chance you go in with no pain. And because obviously surgery is very invasive, it's traumatic to the bones and the soft tissues, you could end up getting pain as a result.
Oh, absolutely.
And it's just not worth the risk.
I had patients...
Or an infection, there's always these small chances.
Small chances, but they are. Now, remember, patients who had bunion surgery by someone probably good and had one bunion which hurt and had another bunion which didn't hurt. Let's do both at the same time so you don't need surgery.
They got 2 for 1.
2 for 1, but the one that didn't hurt, afterwards it hurt.
Yeah.
Why did I have it done? They regret it.
Yeah.
If both bunions hurt, you can have both done at the same time. Because the recovery period is the same. You need to slow down anyway. You've got to follow the guidelines. You can have both bunions done at the same time. Right. But you should not have 2 bunions done if only one hurts.
Yeah.
Only operate on the one that hurts, not on the one that is not symptomatic.
We had a patient actually in our clinic only about 3 weeks ago. Saw one of our physios that sort of specialises in feet, used to work in the ballet. And she only had a small angulation of her bunion, but she was getting some second big toe pain. And they've done lots and lots of work on the strengthening and, being able to move your first toe separate from the second and the fifth and using your intrinsic muscles. And she's done incredibly well. But what I would say is you really have to commit to the exercises to make a difference with that. Because I think with footwear and not always wearing the right footwear, you can end up with very weak feet. Just like if you don't ever do some shoulder exercises, you don't get strong shoulders. So it's very much the same, isn't it? And she did really well with that more conservative approach. But you have to really commit to it as a patient, and that can be an issue.
But as she was a dancer, she was committed to it.
Yeah.
To do that, if you don't do something, to see a physio is not enough.
No.
You need to do the exercise.
Yeah. Sure, come and see a physio, but you need to
it's not enough.
Commit to it. So you mentioned briefly, I just want to go back to the orthotics side of it. As you said, pretty much, if you've got an angulation, you can't reverse it. It's a permanent thing, really. Yeah. Can you slow it down? Can you...
The progression.
Yeah.
You might be able to do that with a silicone toe spacer, with the right footwear, not wearing high heels, but not wearing ballerinas either. You might slow it down, and you also might prevent it getting painful.
Right,
with right footwear.
Yeah.
So we want to make sure that the patient feels on one hand comfortable in their footwear, but on the other hand, London, Chelsea, yes, they want to look nice.
Yeah.
And that's a tricky bit, but they're very good podiatrists who can help with that. But doing the right exercise, working on the intrinsics can help as well.
Yeah.
But you don't get the toe straight again.
So let's say that you've got, like the patient you saw recently, you've done the surgery, and I think sometimes this is something patients don't realise. But do you want to just talk through, because you can talk about what you do in the surgery as well. Some people might switch off. But just talk to me about the post-operative process, because it does take quite a long period of time, doesn't it? It's not go in and go back to running the next day, is it?
Absolutely. And that's when patients are surprised how long it takes. And some don't want to believe it. They later on realize it does take that long. But they should not think that it depends on the type of surgery.
Right.
Whether you do it minimally invasive, whether you do it open. You need to know how to do it. As a surgeon, you need to know you've got the experience with it. There are reasons you want to do one or the other, but you need to know how to do it. That's the first thing. The second thing is it takes a long time. The first 2 weeks, patients should really sit at home with the foot up. They can go to the toilet, get some to eat and drink. They have a stiff sole post-op shoe. And with that, they can walk.
So you're walking around in almost like a plaster boot, aren't you?
Exactly, but it's
not very attractive.
Not very attractive, which probably is good, so they won't overdo it.
Yeah. As in not leave the house.
Exactly, they shouldn't really, because it's like swelling. It's exactly. It's a swelling.
And they've got crutches, haven't they? And
they don't need to. They can have it.
They can put weight through it.
They can walk as normal as you can with that kind of shoe, but they should reduce the amount of walking. They should reduce the amount of sitting with the foot down. It's important to keep the foot up. Yeah. That's very important.
For swelling.
Purely for the swelling. Swelling causes pain, causes stiffness of the joint and can cause an infection, because where there is swelling, there's less body resistance against infection. So that's the first thing. First 2 weeks, really take it very easy. After 2 weeks, you can slowly start doing a bit more and a bit more. But for 5 to 6 weeks, you have to wear that shoe full stop. You might come into London a bit, but you don't
go to work, but you don't want to be on it much at all.
Exactly. Don't do it too often. Nowadays, that's a lot easier from that point.
Yeah.
The new life is a bit easier for my patients, because you should stay at home. You can walk a little bit outdoors. You can go to a coffee shop, but you shouldn't go out to do things. After 5, 6 weeks, the bones have healed. You're not fully recovered. The soft tissues, all that has to get used to it. So it's another 5, 6 weeks. So about 12 weeks,
so
3
like
months.
3 months really
Roughly
to really
3 months.
feel that confidence in the foot.
And you're not running, you're walking.
Yeah.
You increase your activities, you spend more time on it, your feet, but you're not running. That's potentially after 3 months.
Yeah.
That's when you start very gentle and you build it up. It doesn't take 6 months to be able to do things, but it can take up to 6 months to be exactly where you want to be.
And also I've definitely seen patients 2 months down the line where they're doing too much and they end up with basically a synovitis, an inflammation of the toe joint and a stiff joint. So in that early phase, should they be wiggling their toe? Yeah.
They can wiggle their toe, even day one, they don't have to do too much. But after the first visit, they come and see me, I show them how to move the toe.
Yeah.
And that's absolutely crucial. If they have a partner, they should help as well. It's important you start mobilizing the big toe joint. A bit downwards, that's good, but it's more important upwards.
That's what you need for walking, isn't it?
Exactly. You shouldn't do that once you're standing, because that puts so much pressure on it. You need to hold the midfoot and you need to mobilize the big toe. That's absolutely crucial.
I've certainly, over the years of being a physio, done my fair share of big toe wiggling. But it's really important, because if it gets stiff, it is very hard to reverse.
Thank you. You have a nice straight toe, but it doesn't move.
Yeah.
It doesn't work.
No,
Patients are very unhappy. So you need to focus on that. We focus on that intraoperatively. We test it. We see the flexibility. But even with hallux rigidus, the stiffness, when we operate, we get a lot of movement, but we know patients lose it because there's some scar tissue that builds up. And that's normal, but we need to make sure that that scar tissue is stretched out enough so they can mobilize.
So when would you actually, because you put you obviously have a dressing on
10,
after
14 days.
So after that, you can start moving your toe.
You need to.
Yeah. You need
Don't
to.
start after 6, 8 weeks. You missed your chance. You still can work on that, but it's after 2 weeks.
I've definitely seen people overdo it, and I can think of a few cases where it's been very hard to reverse, and that 6 months taken 9 months. So actually, what that says to me as well is that obviously there's no emergency to a bunion operation. But you do need to plan when you're going to do it, because you are going to be off sports. You're not going to be necessarily going into the office too often, and so you need to plan it and make sure that you've got that support at home and everything like that. So in terms of the post-operative, let's say, because I know I get this question, let's say, and you've sort of answered it, but just to put you on the spot, Martin, I've got a runner, but they've got a sore big toe, they've got a bunion, and so how long do you think on average it takes for these guys to get back to running?
Well, I wouldn't allow them.
And you can't say it varies or depends. No.
I wouldn't allow them for the first 3 months.
Right.
That's absolutely for certain. And they should start doing non-impact exercise first. They can do that early. The trouble with that is, as soon as you do cardiovascular exercise, the foot swells. That can cause discomfort, that can cause swelling, that can cause stiffness in the joint, which you don't want to see. So they can put compression socks on. Now, the trouble with the compression sock is it presses the big toe over again.
The sensitive tissues.
Exactly, and you can get a bunion again. Actually. So you could put a silicone toe spacer in there and then wear a compression sock. They will try that twice and that's it. What they could do, which isn't very common here, they could wear a compression sock with a sling for each toe. That works. I bought some for myself just to see how it works. But it's not easy to put them on. But they're very good. They're very good. So with those socks, you can start some activities, not the running, but cardiovascular exercise in the gym, on the stationary bike. You can do that. Then go on the elliptical machine where you don't have impact, but you use your muscles in a different way. And then you should start running a bit in the gym if you have access to that, because when you go out, you don't run for 3 minutes.
No.
You go, I want to do half an hour at least. And you're tempted to do that. Whereas in the gym, doing 3 minutes, go on the cross trainer, go on the step machine, go on the bicycle, do a bit of rowing, you can alternate. And that's fine. That's how you should start. But it's after 3 months, you can start running. It depends on how good the flexibility is. It depends on how much swelling they have. But 3 months, no running.
Okay, perfect. So 3 months is a minimum of what you're
But
going to
most
be
people
off.
can start at that time.
Yeah, absolutely. What about for patients that have got pain? Obviously, as you know, I do lots of ultrasound guided injections. Is there a role for that? Or is it just delaying the inevitable, probably?
For the bunion, there is a role only if they have an inflamed bursa over the first metatarsal head.
Right. So outside the joint.
Outside.
Yeah.
For the joint
I
itself.
think that's fair.
If it's inflamed and they need to travel and there's, yes, you do
Of
the
course,
ultrasound,
yeah.
fine. Otherwise, for the bunion,
Yeah.
can't help too much, unfortunately.
Okay, perfect. And the other thing, just from a physio point of view, following the operation, is it's still important to look at your calf strength, look at your intrinsics, but also look at your calf length.
Absolutely.
Because like any forefoot pain, so any pain at the end of the foot, is going to be, you're going to put more pressure on it, aren't you? If you have a tight calf.
Absolutely.
And footwear is really important.
Footwear is important and the calf muscle is important. So when patients only have a bunion, but they might have a little bit of discomfort, or you see on the x-ray the first metatarsal is already same length or shorter than the second metatarsal, because we have to
because of the angulation.
Yeah. Well, because that's how they are, that's the alignment. And you need to shorten a tiny bit the first metatarsal often to make sure that you can then get the toe over that, because if you keep that, you can't get the toe in the right position. You need to shorten that a bit, and you want to prevent stiffness. So by doing the cut, you might want to shorten the first metatarsal, and therefore you increase the risk that the second metatarsal is relatively too long and you overload there. Even though having had the bunion done, you should take more weight through the big toe, but still it might be shorter and you get trouble here. That's when you look into the calf muscle. If you have advised the patient beforehand doing the stretching, but they have the very tight calf muscle, you might consider doing something for the calf muscle.
At the same time?
At the same time.
What do you think, how often do you think you do that? 10, 20%?
Yeah, probably 10%. We don't do it that often, but when a patient has that, yes, that's highly recommended.
Okay. Yeah. Well, look, Martin, I think that's really, really useful. The key messages for me is that bunions are probably genetic, if anything. I remember a picture that I saw in a presentation where they proved that it wasn't about shoes necessarily, because they said some of the worst bunions you'll see are in African tribes and they've never worn a shoe in their life.
But they might not have pain.
But that's the point, is that just because you may look at your foot and go, oh, I've got bunions, or I'm going to have bunions because of my mother's feet, it doesn't mean you're going to have pain. And there's more people out there without pain and bunions than with pain. However, what I think is really important, what you said, is you may start getting pain in the big toe, and maybe you can manage that. But actually, if it starts going to the toe next door as well, that might be when you need to think about seeing somebody. And that may prevent this just getting worse and worse and affecting the rest of the foot. So there may be a sort of sweet spot where you should at least go and see somebody like yourself to consider it and get the pros and the cons.
Absolutely. No, the second toe is really the important bit. When you start to get to that point, yes, you should be seen by someone.
Cool. Well, Martin, thank you very much. I do hope you don't develop bunions as you get older.
Not me.
No, perfect.
No,
All right. Thanks very much, Martin.
Good. Thank you, Chris.
Thank you.